Sweet. Okay, so we're going to go through the cases that Emma's asked me to go through, particularly around sort of pericardial disease, constriction, restriction. So we'll work our way through these. Just going to give a little bit of an outline once again on the overview of what's going to happen in the Viva, which is what we're going to focus on today. So it's a 40-minute exam. It's about 7 questions we're going to ask you. It's in person this year, so it's not online, and it's going to be done in Sydney. So you'll be traveling to Sydney. I think the last 3 years we've done it online after COVID. I think the examiner's opinion was that we are missing out on a few key things that we can get being in the room, and potentially getting rid of the not insignificant technical complications that happen, which can put stress on people. So it's thought best to do it in person. So when you come into the room, it'll be a small-ish room. It's like an office-sized room, and there will be a computer in there, which I hope will have a decent size, at least 20-inch computer screen. It's not a high-res image, not a high-res screen, unfortunately, but it will be a standard computer screen, and you will be in charge of it. There will be at least 2 examiners in there, possibly 1, sometimes even 2 people observing. But the main people you're going to be focusing on would be the 2 examiners, who will be very obvious, and they will introduce themselves. One person will be asking the questions, and the other person will be timing. The questions will be the same whether Rishi's in the room or Haywan or Robert. It'll be exactly the same questions and exactly the same prompts. So similar to the SICM exam, it's got to be the same with every single candidate. If they are prompting you, don't freak out, because sometimes we just need to try and speed you up a little bit, or sometimes you need just a little bit of clarification. We have to get every single candidate through the 7 questions, or 7 or 8 questions, how many there are. And so there are strict sort of timings that happen for each image. The questions will be marked on, you will be given a fail, borderline fail, pass, pass well, and pass very well. And you will fail the overall exam if out of the 7 questions you fail 2 or more, or you've got more borderline pass, borderline fail than pass. That makes sense. Okay. So there will be critical fails, just like in the Viva exams for the ICU college. Otherwise, you can still pass. Even if you have multiple prompts, you can still pass the exam. And we'll go from there, okay? You'll be in charge of the computer. And that means that the examiner might ask you to move forward at the drop of a hat, because you might have passed all the right things already. And we've got the marking grid will be, it's not rocket science, what the pass and fail is. For example, showing you a bad heart with a bit of tricuspid regurg, you'd be expected to say, there is some LV dysfunction, and moderate or severe would get you the mark. They've got a dilated LA, and you've got some significant tricuspid regurg, might be fine. Okay, so we're not asking you super esoteric questions. Out of the 7 questions, there will be at least 1 which is called point and shoot, and I'll show you an example in just a second. There will be 1 question on general ultrasound, vascular, fast scan, plexus, lung, whatever. Again, at CCPU level, it's not at a super high level, so make sure you've got a little bit of those done. The majority of the exam is TOE or TTE. General rule of thumb as you go through them, we'll practice it today, is about 1 minute per slide. And imagine you're talking to a colleague about this. This is not CCPU level. If you want to start off by saying this is a parasternal long axis, that's fine, but get to the point. Look at you've got 1 minute to get through this question. And maybe if you want to ask questions, we'll pause at the end of each question with these ones. You can ask me what might be in a marking grid, for example, and you'll see that it is not anything that's beyond you. Sometimes we don't always show pathology. One of the things I think that's important for an expert level qualification is knowing when something is not significant. An example would be if you've got someone who's short of breath, there might be mild LV dysfunction but significant MR. You don't have to say that's severe LV dysfunction, and that would be a fail for me. You shouldn't, if something's mildly abnormal, just say it. We're trying to pick you up, but you are expected to be able to pick up normal. Okay. Any questions on any of that before we kick off? Okay. Each case will start off with something that looks like this. It will say, for example, this is case 1, point and shoot style questions. And what we mean by that is literally we're going to show you an image and you've got to say what it is. There's not a lot of fluff that goes with it, as opposed to some of the other questions that are going to have a stem that is obviously relevant. So it would say this is, I think I actually just copied this directly from the exam a couple of years ago. So it says case 1, point and shoot style questions. Each slide is a different case. Discuss your findings after each slide. No one was reading it out for you, sorry. You have to read it for yourself, and you can read it out loud or you can just read it to yourself, whatever you want. You're going to have 7 slides, and we're going to give an estimated time frame to get through this question, which is 8 minutes. What I was going to suggest is that we'll just go around the 3 of you and you can have a go. And this is kind of like a warm-up phase. Normally we put this in first. That's how I did it when I prepared the exam. Yang is in charge now, so I don't know how she's going to want to play it. But normally we put these first up just to warm you up. So hey, one, happy to go?
Yeah.
Okay.
So that's pulse wave Doppler in pulmonary vein. It's an abnormal pulse wave Doppler trace with S wave being shorter than the D wave. The multiple causes to this. Firstly, increased left atrial pressure. It could be due to atrial fibrillation, although the ECG trace there looks regular and sinus. Other causes could be mitral regurgitation, at least moderate in severity. Yeah.
Oh, excellent. The only one I was going to say is just raise left ventricle end diastolic pressure if you've got horrible hypertrophy or a bit of aortic regurg. That's going to give you raised LVP. Yeah, beautiful. Clear pass. Click, move on. Rob, you're next.
All right, so 52-year-old female with lupus, short of breath, describe your findings. So all 3 images are demonstrating a large circumferential pericardial effusion. Of note, there's evidence of fibrin stranding on the zoomed in view, so the image on the bottom right corner. Just looking for evidence of tamponade. I'd have to slow it down, but it appears like there may be some RV diastolic collapse. It'd be nice to see the timing of that.
In the exam, you can, just the same as I do, if you hover your mouse over it, it'll be this kind of thing on a PowerPoint, right? You just can press pause and then you can grab the little thing and move it if you want to. It's not absolutely essential, to be honest. All we need to hear is what you're really looking for. Sorry to interrupt.
Sure. So I think there looks like there could be some RV diastolic collapse. I'd like to time that with the ECG. The right atrium, likewise, looks like there could be some systolic collapse of the right atrium. But
thank you very much. What do you think might be the cause of this effusion?
It's probably in the setting of the lupus. So patients with lupus can get a serositis, for example. But it could be a multitude of things. If she's on, it could be infective if she's on any sort of immune drugs, or it could be if she's had a procedure, could be blood.
That's good. We'll move on. Nice one. Yeah, and I guess just I think what would be after, if there was a marking stem for this, it was the idea of transudate versus exudate when you've got lots of fibrinous strands in a in a pericardial effusion. So talking about, I think that was all that would be needed for that. But if you say things like infection and serositis, I think you get the tick. Not bad. All right, Rishi, you're up.
So we're looking at a strain curve, which is showing a preserved contractility at the apex and reduced contractility at the basal anterior and lateral walls. This could be indicative of a systemic disease like amyloidosis, like a cherry on top appearance.
Anything else?
In addition to that, we have to rule out acute myocardial infarction,
That's fine. You said it was a strain curve. Can you just elaborate on that a little bit?
So it's a bullseye plot for when we are doing strain, we're imaging for strain in left ventricular walls, looking at the global longitudinal strain.
Excellent.
So,
and what do the different colors represent?
So the red represents preserved contractility, blue represents akinesis. So there is lateral wall akinesis.
Thanks. We'll move on. That's great. So yeah, very nice indeed. So just again, just get your language just a little tighter. You said, I think at the beginning, you said it's a strain curve. This is, as you corrected yourself, this is a bullseye plot made up because of the strain curves. And then there's normal and abnormal strain in there. And here you've got apical hyperkinesis relative to basal hypokinesis. And the only two pathologies that really spring to mind for me are amyloid, like you said, with a cherry on top, which is what this is, or it could be a reverse Takotsubo, but that's a bit echo geeky. That would not be a fail. You'd clearly would have passed that. That's that one. Excellent. Okay, back to you, Haywan.
Yeah, let me just spend some time looking at this image, sorry.
You got a minute.
Yeah. I think look, there's an M-mode cursor across the short axis of across RV and LV, and I think there's diastolic LV collapse. I'm sorry, RV collapse with pericardial effusion. Yeah, and I'm concerned about
the green
tamponade
line
physiology.
across the bottom.
Oh yeah, so that's the respirometer. And I'm trying to see if there is sort of abnormal septal movement associated with it. So it's suggestive of constriction. But I can't see that.
What would be the that would be everything I could think of. So those would be the kind of 4 marks I would have thought for this stem showing you that is picking up that there's a pericardial effusion, that you've got some RV free wall collapse that looks like it's during diastole, having an idea that there is that respirometer in there, and remembering that you're going to see septal bounce with tamponade, which we'll come onto in a sec, and that you're seeing some form of respiratory phasic changes of that septum moving in during particularly inspiration there. So yeah, really nice, picked it all up, tick, 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 move on. And you do, no need to second guess yourself. You've got this, you're absolutely right. You didn't need any more time than that. So yeah, great job. Okay, Rob, back to you. Oh, Nick, hey, so you're asking a question?
Oh, yeah, sorry. I can ask afterwards if you want to keep the flow going.
No, go for it.
Can I just check with the M mode, the little, describing an M mode, but the little squiggle in the middle that I think is the mitral valve, like the EA pattern of the mitral valve.
Yeah.
It looks like on this, if you move 2 cardiac cycles, or no, it'll be 6 cardiac cycles along to the right, one further.
Yeah.
There's collapse of the RV free wall, and then it seems to be bouncing back concordant with that E wave of the mitral valve opening. Is that?
Yeah, I see what you mean. Just
So
in there,
yeah, I'm just trying to work out if you would call that, if it seems like the RV free wall is then moving outward as the mitral valve, that's presumably the beginning of my mechanical diastole.
Yeah, good call, good call. So you're thinking it actually looks like it's late systole almost.
Yeah, that's what I'm wondering.
Yeah, good call. I agree. I mean, I still think if you have a look at the ECG down at the bottom, maybe it's not completely in synchrony. I do think that we're seeing what looks like to me early diastolic RV collapse. Remember that the RV and LV do have slightly different timings for their filling, and the RV fills before the LV. So when we're talking about diastolic collapse, it's diastolic collapse for the RV, so that can happen a little bit before the LV. So I still think that this, based on the ECG and the fact that we got a pericardial effusion, I think we're probably, I think Haywan will certainly get the marks. How about we say it for that? Yeah. I think when we're dealing with M mode, also after you.
I was going to say, it sounds like don't rely on the mitral valve entirely as you're timing the ECG.
Correct.
more so. Okay.
Correct. And again, I feel like with some of this conversation, we have a tendency as doctors to slip into the geeky aspect of some of this stuff, trying to keep it super clinically relevant. If we're getting to this level of discussion, we've probably slipped off from actually what's important clinically, which for me is this patient short of breath? Do you have signs of tamponade, or do you have impending signs of tamponade? Do you need to drain this effusion? And I can't remember where I got this picture from, but if this patient was completely normal, of course, we don't need to drain the effusion, as opposed to if they're short of breath and they're a bit sick and they look like they're coming to ICU, I would absolutely be draining this effusion, if for no other reason, just to take out the risk of tamponade being in the diagnostic criteria. Does that make sense?
Yes, thank you. That's perfect.
No trouble. No trouble. Cool. All right. Who's next? Rob, is this you? Yeah.
Yeah. All right. So this is an 84-year-old male collapsed after complaining of back pain. He's unconscious and barely palpable pulse. POCUS describing findings. So again, there's a large circumferential pericardial effusion. This one appears to have echo density within it, so it's heterogeneous in nature, and given the history, I'm concerned that it could be blood. There's evidence on both the apical 4 and the sort of modified parasternal long of chamber collapse, so the RV seems to be collapsed most of the time, so presumably during diastole. And just being aware that we could have some off-axis imaging here, but it appears during portions of the respiratory cycle in the parasternal long that there's some collapse of the left atrium as well, which is concerning. I'd also note that the aortic root is dilated and there's effacement of the sinotubular junction, which would be concerning for dissection causing this tamponade.
Great job, mate. Great job. Great job. Fantastic. Tick, tick, tick all the way through. And you even didn't need me to ask you about what the pathology is. So yeah, very nice picking up that there's blood in the pericardial space. There's lots of, there's a distinct lack of blood within the heart chambers because you've got significant tamponade effect. It's a small pericardial effusion, but it's got heterogeneous material inside it. And absolutely, there are only a few pathologies that can cause that, and even fewer when you're talking about a guy who's just collapsed at home. So yeah, absolutely. This is dissection. You've got blood in the pericardial space, and this is tamponade physiology. Very nice. Okay, Rishi, you are next. Sorry,
Yeah.
language. You are next.
Yeah. So 65-year-old gentleman with HFpEF. Would you like to confirm left atrial pressure? So EBI, the additional information I would like to have is the TR velocities, TRV max, and the left atrial volume index.
Anything else?
In addition to that, if possible, I would like to know the pulmonary vein Doppler velocities, if there, and the 2D picture of the size, the shape of the left atrium.
Yeah, no, excellent. I was going to talk about D-cell time. You can actually see it in there, but I hadn't given a good thing in there. I like the D-cell time just because it's just any piece of the puzzle. I mean, to be fair though, it was already in there, but if it's less than 160, that obviously looks more like the restrictive thing, as opposed to greater than 240. That's kind of normal. And yeah, they're not trick questions. They're literally these questions are just about getting you into the swing of things. So yeah, tick, tick, tick. Everyone passed all those beautifully. Okay, that's the end of case one. So we'd go through those fairly quickly. As I said, we're not trying to trick you up in any way at all, but you are expected to say things with confidence. You know, you've got to come away, the examiners have to come away from that time with you thinking that you are confident and competent. So trying to talk slowly with clarity and confidence is a great way of promoting that. Being nervous is okay. Everyone expects you to be a bit nervous during the exam, but when you're nervous, don't forget that you're going to have a tendency to overcall things and miss pathology. And that's where these bad fails come in. So if you're overcalling things or you're missing pathology, that's where the fails come in. So nothing, you know, all of you guys, the knowledge is there. So this is exam technique, which is what it's about. Okay, we'll just do another couple of point and shoot questions just to make sure that you've got this, and I'm sure you do. Okay, hey one.
So it's the location in relation to the descending aorta. So in this image, the effusion is anterior to the descending aorta, so it's a pericardial effusion. Actually, there's also pleural effusion as well in this image. Yeah.
Anything else about a pericardial effusion apart from the location for the descending aorta? I'm just going to say it's circumferential.
Oh, sure. Yeah, of course. Yeah, yeah.
And if they're asking, and bear in mind that if you say things that quickly, that does mean the examiner can sometimes try and ask you a question to get you, you know, all the marks that are in there. So
okay.
if they're asking you a question, it's not always because you're, you know, you need a prompt. It's just they're often just trying to squeeze every last mark out of you. So yeah, again, don't be worried if they're asking you questions. All right, Rob, all yours.
So generally with a fat pad, the motion is, I guess, in keeping with the myocardium, and you'll see some echo texture within it. So like for this, for example, to me looks like a fat pad, and it's also restricted to the RV section. There's nothing posterior to the heart. So although that can happen, I think here this would be in keeping with a fat pad.
Very nice. Rishi.
50 ml.
Have another thing.
How much?
Can you be a bit more specific? Do you have to be in tamponade if you got 500 ml?
You could be in tamponade, but you may not be in tamponade as well. So tamponade is like a clinical diagnosis. It could be with any amount of fluid. It could be localized. It could be circumferential.
Yeah, it's a silly question. We probably wouldn't ask it like that. I just wanted to make sure that we can get clear in our minds about the tamponade. You're absolutely right. It is a clinical diagnosis. So if we're showing you echo pictures, you can't say whether they're in tamponade or not. And the next thing is just like that case that Rob just spoke about. That was a patient with quite a small pericardial effusion, but they were clearly in tamponade because they were trying to die with barely palpable pulses. And that's because they've got a small amount of fluid, like 50 mils, that accumulates rapidly. So it's not about the volume, it's about how quickly it comes on. You can have 700 mils of fluid in your pericardial space and walking about because it has come on over a long period of time. So it's about how fast it comes in rather than the actual volume. Hey, one.
So it's end diastolic RV collapse and early systolic RA collapse.
Yeah, very nice. So just the lowest pressure in the cardiac cycle. So for the RV, the lowest pressure is at the beginning of diastole, and then for the RA, it's RA diastole, which is RV systole. Yeah, so very nice. And there you can see it there. So diastole for the RV collapse, just like I said before. Rob.
Clinical features of shortness of breath and shock. What do you call the following echo appearance? This is again a circumferential pericardial effusion with what looks to me like RV diastolic collapse, along with particularly the right atrium. You can see there's significant collapse of that chamber. The IVC, however, is not plethoric and has got respiratory variation. So I suspect this is a low pressure tamponade setting.
Beautiful. I call it pseudo tamponade. Yeah, very nice. In real life, the importance about recognizing this is you obviously can potentially give this patient fluid, increase up their intracardiac pressures so that you no longer have the free wall collapse. And the signs of tamponade, generally, I find that you do have to drain them. That it doesn't just disappear just because you give them a bit of fluid. Yeah, nicely done. Rishi.
So the septal bounce is is caused by the respirophasic variation in chamber filling across left ventricle and right ventricle, across inspiration and expiration, as well as the limitations of the chamber filling because of the restriction imposed by the pericardial effusion itself. It's
Beautiful.
different.
So when does the septum move in the respiratory cycle?
So in inspiration, the RV starts filling more, so the septum moves towards the left, and on expiration, the opposite happens. It's different from septal shudder, which happens from beat to beat.
Nice, like that. Anyone?
Yeah, so the equation is the difference between expiratory and inspiratory peak velocity divided by expiratory velocity. The cutoff is 30% for the mitral valve and 60% for tricuspid valve.
Yeah, it depends on which guidelines you lead. It's significant. So yeah, I think there's some they talk about 25 and 40 for the mitral and tricuspid. Others talk about 30 and 60, which is what I use, which is probably where you got it from. Yeah, perfect. Okay, so those are the kind of point and shoot style questions. They are generally, again, at the beginning, they're not meant to trip you up, just to kind of get you into the swing of things. Any questions about those? Everyone happy? Okay, well, we've got 3 more cases and we've got about half an hour or so. So why don't we start with Rob? Do you want to do the first one?
Sure.
Oh, sorry, maybe before that, can I just show you this? I got this, this is from our friend Chris Duncan. He's working up in Newcastle now. He put together this really nice collection of images about draining a pericardial effusion a while back that he's put into a video that I saw. But they've asked about this in the exam. I don't know if, I know that draining effusions is sometimes not a super common thing that we do, but knowing how to do it with echo guidance has been asked in the exam before. And if you haven't seen it, I think this is a really nice presentation going through it. So first of all, obviously you all know how to diagnose the effusion, but when it's coming to then draining it, we'll just go through this again. So say you've made the diagnosis and you want to drain it. Often you have you'll use echo to figure out where to put the needle in, but then you give it to a friend to image from a different direction. So particularly, I think the safest is going, in the subxiphoid space to drain the effusion, and then you have a friend who puts the probe on the apex, and this is what happened here. So as we start off, this is the baseline study. You can see we've got a big pericardial space, and then we're going to start draining it, putting the needle subcostally. Once we're in there, you can inject. The way I do it is once you see the fluid coming out and you think you're in the right space, I just take the needle, take the syringe off the needle. I pull in about 1 ml of air, and then I put the syringe back on the needle and I squirt in about 3 to 4 mL of the fluid with the air. And that's what creates those lovely bubbles that you can see here, which confirms that you're in the right space. If you want to be extra careful, you can then check that the wire's in the right place. So then you put the wire in, you can see a little artifact. You can also then confirm it when you're dilating it up, and you can see the dilator looks a little bit different. It's got a bit of a ridge, and then you can confirm it flowing through, and you can see the needle, you can see the pigtail catheter in there. I then do it again just to double check. You do the same thing, injecting a little bit of agitated saline. And then further again, after you've drained off, I classically drain about 250 mils at a time, but then go back and check with your echo probe to make sure the effusion's getting smaller. Surprisingly easy if you've got a pleural effusion as well as a pericardial effusion to drain a pleural effusion subcostally. So again, just making sure you're in the right place. But I thought that was a nice demonstration of what it should look like. And again, if you haven't done it before, but you have to describe it in an exam, just remember that. Okay, cool.
Yep.
Right.
So
Rob.
Yeah, 40-year-old male, IVDU, recent discharge for PE and MSSA bacteremia. Ready presentation 1 week later, borderline hypotension and breathless.
Good to go?
Yep. All right, so the parasternal long and short axis images both show a circumferential pericardial effusion. Just looking to see if there is evidence of RV chamber collapse during diastole, which I can't see from these images so far. The nature of the effusion from these images appears simple, but I'd like to see it from other angles to see if there's any evidence of fibrin stranding, particularly given the history of IVDU, etc. And commenting on the cardiac function, so you can see that the LV systolic function is preserved. The RV appears to me like it's dilated and potentially even hypertrophied, and there is evidence of paradoxical septal motion, which appears to happen during both the cardiac cycle and well, it appears to be happening during the cardiac cycle. You've only provided me with one beat, but I can see that it's occurring during both systole and diastole, which would happen with RV pressure and volume overload.
Good man.
The valvular,
thank you.
Yeah, no worries. Yeah, so confirming now from this image, which doesn't appear to be off axis, but there is severe RV dilation with increased trabeculation, etc., consistent with probably RV hypertrophy. The LV chamber is subsequently collapsed from that RV dilation. Looking at the pressure from the tricuspid regurgitation, so just to criticize the image a little bit, they've probably been a bit generous with where they put the velocity markers. But either way, there's evidence of pulmonary hypertension with increased RV pressures. And that's in the setting of what appears to me to be significantly reduced RV systolic function. So both longitudinal and free wall function, the RV is impaired. Now looking at you've shown me a pulse Doppler across one of the valves. Now, to me, it looks like it's probably across the mitral valve. I'd like to confirm that, but this is showing
it is,
respirophasic variation in flow across the mitral valve. You haven't given me any velocities, but it looks significant. If it were more than 30%, then that would be in keeping with potential tamponade. However, I have to note that the patient has got, like I said, RV dysfunction and probably pulmonary hypertension, and so that can also happen in these conditions.
Do you think this patient's in tamponade?
Tamponade is a clinical diagnosis. You said that they presented
short of breath and hypotensive.
Short of breath and hypotensive. Many potential etiologies for this. I can't see evidence of tamponade so far. I think that I wouldn't rely on one factor alone that you've shown me. So I haven't seen chamber collapse on the right side. I haven't seen left atrium.
That's great. We'll move on.
Yeah. Okay, so this is subcostal imaging and M mode through the parasternal. So starting with the subcostal imaging, there is some heterogeneity, or looks like bubbles within the.
There's no one's attempted to do any drainage here.
Okay, so this could be some evidence of exudative effusion. And like I said, that'd be concerning given the history of IVDU, etc. You can get infective effusions. With the subcostal imaging, you can see that respirophasic change in chamber size, and there does appear to be potentially some RV diastolic collapse in this image. Here, I'd like to see the IVC, see if it's plethoric. And then here we've shown me some M mode through the RVOT and the aortic root, etc. And I can see, just going through the cardiac cycle, I think there is RV diastolic collapse here, which just wanting to time it out, but it's potentially.
That's fine. We're just going to move on.
Yeah.
So the final part is having a look at these and describing your findings and tell me what your further management would be and what are the risks.
So this is, again, looks to me like if they haven't done anything and they haven't instrumented the effusion.
No, this is just different angles of analysis.
Yeah. It's looking more to me like an exudative effusion. So in that setting, regardless of whether there's tamponade or not, the patient needs source control. And so to manage this, ideally it would be with a cardiac surgeon for a washout. And again, like I said, you can see some evidence of chamber collapse with the respiratory cycle. And so I think there's significant risk of tamponade with multiple echocardiographic suggestions of tamponade.
Yeah, and what are the risks down the track?
So the risks down the track, sorry, I didn't see that part of the question. Risk down the track will be, if they wash this out, the patient will be at higher risk of having pericardial constriction, because there will be lots of scarring that will occur from the infected effusion and the washout.
Yes, excellent. The only thing I'd add is there's poor prognosis with this. You know, this guy ended up growing MSSA in his pericardial fluid. That's what we drained out of it on his way to surgery. And yeah, absolutely brilliant answer. Source control is key. The tamponade discussion, I imagine if we were to put this in the exam, it would be along the lines of whether you say that you do think they're in tamponade or whether you don't think they're in tamponade is not the right or wrong answer. It's having a reasonable thought process with it. You know, you might say this guy has got tamponade physiology, but we just don't have significant RV collapse because he's got the pulmonary hypertension. He's clearly got one of the things I might just have liked to have heard, but it's not pass or fail, but it's the idea that he got that very thickened RV, free wall, heavily trabeculated RV. There's a lot of chronic features. He's got PE in the past before, so this pulmonary hypertension is not just acute, it's clearly chronic, which means that the right-sided chambers don't collapse as much, and therefore you're looking more at left atrial pressure collapse, which I think he was showing there. So he may have tamponade physiology, but it's not from the RV collapsing. In the end of the day, just like you said, who cares? This guy needs source control, you need to drain the effusion. So it's just some form of discussion around the difficulty of diagnosing tamponade when you've got pulmonary hypertension, and you described that case extremely well. So yeah, strong pass, Rob, nicely done.
Thank you.
All right, Rishi, you ready for the next one?
Yeah.
Go for it.
65-year-old man with increasing shortness of breath, past history of congestive heart failure.
Good to go?
Yeah. Okay, so we're looking at parasternal long axis views. The most obvious finding is a concentric left ventricular hypertrophy, but would like to measure in other close-up views, and a significantly enlarged left atrium, a severely enlarged left atrium, and a RVOT which is enlarged with evidence of mild dysfunction. The aortic valve opening, the aortic valve appears to be opening well, and the aortic root appears normal. Yeah, the measurements are already given here, so there is evidence of a constant.
So the interventricular septum is 15 millimeters, and the posterior wall is measured at 12 millimeters.
Yeah, so there is evidence of eccentric hypertrophy, more septal asymmetric hypertrophy, mostly septal, with evidence of speckling along the myocardium, which is suggestive, which is more suspicious of any infiltrative disorder.
Is there anything else outside of the heart?
So outside of the heart, there appears to be a trace pericardial effusion, which may be a mild pericardial effusion, which we can see in both systole and diastole. And along with that, on the long in the deep view, we can see a pleural effusion on the left side.
Nice job. Nice job. Okay, Rishi, I may just, I'll forget if I don't say it as I go. So don't forget this idea of seeing the whole heart. You're absolutely right. You jumped in to look at the LV. You've got it there. You know, got the speckled appearance. You've got the significant thickening. It's concentric. You called it eccentric, I guess. I was going to say that everything is thickened, and you've got it's over 200 grams, which I think puts it more into the concentric area, but it's not a big deal. You've got huge left atria that you picked up. RV doesn't look completely normal. You called the aortic valve opening normally. I think it's probably a bit thickened and a bit of mildly reduced opening. Again, not pass or fail, just thought I'd mention it. But so you're starting to immediately think about what pathology?
So some kind of restrictive cardiomyopathy.
Yeah, nice. And you mentioned obviously with the speckling appearance, and obviously we'll come on to it in a minute. We'll talk about it later. So what else happens with restrictive or infiltrative cardiomyopathies? You get massively dilated atria, and you're going to get buildup of pressures. And then at the end stage, you worry about pericardial effusions, and you worry about fluid buildup. So I could have said this guy had lots of signs of congestion, but I thought it was going to give the game away. The next thing is the bad features. Well, what are the bad features of something like amyloid?
So the bad features is evidence of, severely raised left atrial pressures with backward filling congestion, and which could have led to the pleural effusion, which we can see here.
Nice, excellent.
In addition to that could result in pre-capillary pulmonary hypertension, post-capillary pulmonary hypertension followed by pre-capillary
really nice.
And then leading to heart failure.
Arrhythmias, I was going to say in there as well.
Yeah.
So those would be, you passed that question very nicely. I just had to do one minor prompt, but just don't forget what's going on outside of the heart in these diseases. I don't think it's obviously as important when you're looking at tamponade probably to look outside of the heart because you're already focused on the pericardium, but just don't forget to come and have a look. I mean, I think he's probably looks like he's in sinus rhythm at the top. I'm not quite sure, but just getting those things like in HOCM, another great example would be HOCM, right? If we're talking about cardiomyopathies, AF is a big deal in HOCM. So if you're looking for systolic anterior motion, or you think you've got asymmetrical hypertrophy and a guy is in shock, just take it to that next level, because that's what we're looking for. That's what we're looking for, someone to be able to diagnose. Is there the pathology present? If it is, what are the features you're looking for, and prognosticate it for me? Are we at the mild, moderate, or severe end of that disease? And clearly on this, I think we're at the severe end, because you've got very thickened walls. You've got what looks like pericardial effusions. You've got huge atria. You've got a speckled appearance. We're ticking the box for all the features. Cool. Keep going.
Yeah, so looking at the short axis views again, we can see a concentric hypertrophy of the left ventricle with preserved ejection fraction, and a severely dilated right ventricle with no evidence of flattening of interventricular septum either in systole or diastole. Again, looking at the far field, there does not appear to be prominent B lines or any evidence of prominent congestion, and the patient still is in sinus rhythm.
Nice. What about function? Do you think there's any difference?
In terms of function, the LV function, appears to be on the low end of normal, but the RV appears to be severely impaired. If severely dilated, severely impaired.
What do you know about regional wall motion abnormality in amyloid?
So amyloid, I think they predominantly affect the base and the mid region with preserved contractility at the apex, but they can be varied and they may not fit to a particular coronary artery territory.
Yeah, very nice. Are we seeing that here?
Yes. It appears to be, I have to pause it and look it, but there appears to be hypokinesia in the anterior and anterolateral region.
Yeah, okay. Just be careful not to overthink these again. I think if we're going to be showing you, because there's not a lot of time in the exam, so every single thing that we're going to put in has some relevance. And I put these in there because, again, let's think about what we know about amyloid. And you said it very nicely when you were talking about the the bullseye plot in those point and shoot questions is that the basal part of the heart doesn't move as much as the apical side. We have relative apical hyperkinesis. And if I can just ask you to have a look at the apex here versus the base, you can see that the apex is contracting much more than the base of the heart.
Yeah.
And so I guess nothing you said there was a fail, but it just wasn't a good pass.
Yeah.
So the pass would be that you recognize that there's maybe some RV dilation, that the LV function is either taken normal or mildly down. You said low end of normal. That gives me the shits, but that's okay. It's not wrong. But the pass thing would be, I think that you'd have probably got like a borderline pass for that. But the pass would be is that you recognize that you're dealing with amyloid. We got that severely thickened ventricle. It's concentric. I've already showed you pictures before of big left atrium, speckled appearance. You've got to take what you had before and keep rolling with it. Yeah. Because then you saw your pericardial effusion. The next thing that I'd be thinking of is, do we have that classic appearance? And I'm not just going to show you the apical 4-chamber view because that's too easy. It's obviously coming. But you should be able to have picked it up on this short axis. So I guess as you're going through these, just keep that level of thinking that, synthesize information, I guess is what it's about. Just like when you're doing a hot case, it's like solving a puzzle. And the key is I'm not asking you what are the key features of amyloid, because then you'll just rattle them off. And even if you've read a textbook, you can get them. The tricky bit is then synthesizing that information. You've got to go short of breath. It's got acute on chronic component. We've seen our parasternal, then we're going to look at the next thing, then we're going to look at the next thing. It's just these layers that come onto it, and you're building your process through there. And so your confidence about diagnosing amyloid should be going up with each section. Okay? So then have a go with this one.
Yeah. So looking at the 4-chamber views, again, confirming the presence of left ventricular hypertrophy with normal ejection fraction. RV size appears to be moderately dilated with moderately reduced function. There is severe biatrial dilatation. On the color flow on the right, there appears to be a mitral regurgitant jet with some early pizza formation, which in the context of the severely enlarged left atrium would prompt me towards considering the severity as to be moderate until I see further images and I have further information.
What do you think about the LV walls?
So in terms of LV wall, we're looking at the anterolateral and the inferoseptal walls. There appears to be there's no regional wall motions abnormalities at this stage. The base appears to be again have reduced contractility compared to the apex, which seems to be contracting normally, but base appears to be on the to have reduced contractility.
Nice. So, and I think this one again shows probably the best out of all of them about that speckling appearance. It's not great for diagnostic purposes for amyloid, but could be worth mentioning again for the solid pass. And the last thing is about those severely dilated atria. Forgive me if I missed you saying that, but the striking features for me on this echo, and again, just jumping into the big parts out of everything you've seen, is that severe concentric hypertrophy, that relative apical hyperkinesis and basal hypokinesis, severely dilated atria, moderate mitral regurg, secondary to probably left atrial dilation. Again, if you've got moderate or severe, any valvular disease, tell me the mechanism. Those kind of things have got to pull it out. I've got a significant interventricular conduction delay, which again is, can be bad when you're looking at amyloid, and you've got thickened valves. So just getting that kind of pattern going through with confidence and going for the big stuff first. Because I think you started with talking about the right ventricle being moderately dilated. I'm okay with that. Obviously, I think it's all about the right ventricle. But I think, unfortunately, this is about amyloid, right? And so with what you've seen before, just building things up. And as you're building it up again, am I dealing with mild, moderate, severe? This guy has not known to have amyloid before. I need you to diagnose it. Or I need you to say there are strong echo features of amyloid cardiac disease in this patient. We need to dramatically change the way that we're thinking about this guy. Because first of all, it's a terrible diagnosis when you're old. And second of all, he's got lots of features that suggest that this is severe disease. Trying to reverse this will be very, very hard. You know, the good candidate is starting to think, okay, if he's in ICU with this, this is a death sentence, man. You know, if you're really sick and you're coming into ICU with these kind of features, I'm not going to be able to reverse very much. I'm not going to stick you on a ventilator. I'll do what I can, but there's a lot of irreversibility to this. Yeah, do you know what I mean? So it's that kind of synthesis in there. This is not just, oh, this looks like amyloid. It's taking that and putting it into the stem of the question.
That's
Cool.
good.
I still think you'd have passed this, by the way, but I just think you could have squeezed out a bit more then. I think there are prompts in there that may have got us down to like a borderline pass as opposed to a pass or a pass well. And I think we just need to, you know, your knowledge, you're clearly up in that pass well category. So we just need to squeeze it through. And this would be the last bit of it. So the last poor prognostic feature for me of someone with amyloid is a reduced cardiac output.
Yeah.
So, you know, as you're looking at these images, I want to be able to, hopefully you to start thinking of how you're integrating that with this guy who's now short of breath and coming to an ICU. And then what are the features that you need to look for to help care for this guy? And unfortunately, I think the thing, if I had a, you know, how are you going to manage this patient? Well, you know, you're going to want to involve people, look at biopsying it, look at the kidney function, look at ECGs carefully, send off, trying to look for the infiltrative disease process and the abnormal proteins. But there are lots of features on this that look towards severe. There's an element of irreversibility to this. I'll be wanting to have a chat with the family and the patient about where we're going with this patient. You know, that's the tick, 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 tick for me. Cool.
Yes. Thank you.
Okay. Last one. Oh, sorry, and this is the last bit. So again, with amyloid, there are pathognomonic features of it. What are we looking at here?
So we are looking at mitral inflow velocities as well as the tissue Doppler across septal and lateral. So the inflow velocities in restrictive cardiomyopathies are typically very raised E waves, very raised E by A ratio, so more than 2:1 are usually typically of restrictive. And on tissue Doppler, the pathognomonic features are, especially in amyloid, is severely reduced septal and lateral tissue Dopplers, typically less than 5 centimeters per second.
Yeah, and it's called the 555 sign. So don't. It's not just about the E wave. What are the other bits in there?
S
What's the
wave,
555 sign?
E wave.
Nice,
And
excellent.
wave. So
So that's what we're seeing down
are,
here. Okay, everything is less than 5. The S wave, the E wave, both on medial and lateral. So cool. So as you know, that's the way that these kind of cases would go. I think this would be a beautiful case to stick in the exam. And the good candidates start thinking of that as they go through, just building information. You know what you need to see next. Or I could have shown you an apical 4 and say, what other imaging would you like? And you'd talk about, you know, tissue Doppler, LAP estimations for all those things you mentioned, looking at speckle tracking to see if there's the cherry on cake. You know, those are the different ways they could ask that question.
Yeah.
Hey, do you want to really quickly just smash through this one?
Yeah, sure. So 52-year-old Pacific Islander, acute and chronic shortness of breath, history of rheumatic pericarditis and TB, with very abnormal chest X-ray. I mean, I can see some calcification around the pericardium there on the X-ray, bilateral infiltrates. Yeah, large effusions.
Yeah, great job. Great job. So what am I about to show you?
The constrictive pericarditis.
Very nicely done here. Well, very nicely done.
Yeah, a very abnormal transthoracic echo. What strikes the most is sort of septal bounce, which makes me worried about constriction. Also, the RV is dilated, and I think it's both pressure and volume overloaded. LV function is also abnormal. I think it's at least moderately impaired with severely dilated left atrium.
That's great. We'll move on.
Again, on the 2D image, I think at least moderate biatrial dilation with sort of septal bounce, again, which is abnormal. There's a mitral inflow pulse wave Doppler showing respiratory variation, which can happen with constrictive pericarditis, other differentials being things like severe right heart failure, pulmonary hypertension, but we haven't seen an evidence of that just yet.
Very nice.
Yeah. So I think, yes, that's mitral inflow pattern again, showing restricted pattern, tall E waves with sort of almost absent A waves. It's very, again, showing restrictive pattern. And then the next image is, I think that's pulse wave Doppler across the pulmonary vein, showing
Excellent.
blunted S wave.
So what's the what do you think, putting all that together, that's that show?
Yeah, so I mean, look, I'm worried about constriction with abnormal septal bounce, restrictive movement across restrictive filling pattern, and respiratory variation.
Just from these pictures, what do these pictures indicate? Thank you very much. Yeah.
Again, this sort of apical four-chamber image, I don't think it adds much to what we've already seen. I think I'll just be repeating what I've said earlier.
Yeah, no, it's just, I think probably you talked about a septal bounce before. What would be key about this is recognizing that we've got more cardiac cycles. So before I'd only had like one or two things, and you talked about septal bounce. Can you just expand on that with this picture?
Yeah, so, what I would want to see is the septum moving towards the LV during inspiration and the opposite direction during expiration. That's just exaggerated sort of cardiorespiratory interaction.
Very nice.
Yeah, so again, it sort of confirms the clinical suspicion with very high medial E prime, sort of almost at 16. Lateral prime is also elevated, but sort of medial E prime is higher, also known as sort of annulus reversus. Again, a finding supportive of constriction.
Yeah,
so that's pulse wave Doppler and collar flow Doppler across the hepatic vein. What I am expecting to see is expiratory reversal of pulse wave Doppler signal. There's no respiratory, respirometer, but I mean, I suspect that's what I'm seeing here.
And what's reversing? You said it's during expiration, but what are we looking at that's reversing in expiration?
Oh, it's the A wave, isn't it? It's A wave.
Yeah, diastolic flow reversal.
Oh, sorry, diastolic flow reversal. Yeah.
So that's what we're seeing just there. So it's sort of during diastole, I think you're getting that flow reversal during expiration. And that was just, so if it's constrictive, it's during expiration. If it's restrictive, it's during inspiration. But that's more if you're doing the American Echo Board exams. They love asking about that.
Yeah.
Very nicely done. And this is just he went off and had a right heart cath. So strong pass, A1. Very, very nicely done. You got it right from the beginning. And here you can see on that chest X-ray as well as on this angio that calcification around the heart. And then they had a right heart cath. And the feature that sort of clinches the diagnosis is that equalization of diastolic pressures throughout all four chambers of the heart. And then it's got that thing, I think it's known as the square root sign, which is the prominent X and Y descent on the venous flows. And then you'll have an end of the exam and you can walk out of the room. Excellent. Well done, guys. That was passes all along the way. Are there any questions you'd like to ask me about that? That's a sort of close to the exam kind of format I hope to be able to show you. It will have that black background. It will have that beginning and end of each question. It will be about a minute per question. It will be around the cadence that we've just gone through it now. So getting through your findings, the relevant positive and negative findings as quickly as you can is what it's about. Any other questions?
Sam, hi, Zoe here. How are you doing?
Hey, Zoe. Yeah, very well. Nice to see you.
I'm wondering if you can give an example of a critical fail for the GDU exam.
Yeah, okay, let's maybe I could try and think of what a critical fail would be like for these. Okay, so critical fail, why don't I share my screen again? Sorry. I'll make it up a little bit as I go through the questions. Okay, so critical fails would have been lack of recognition of these point and shoot. So, you know, not recognizing that there was respiratory variation. There would be the critical fail. Case 2 be lack of recognition of their transudate versus exudate. I know Rob talked about this one. He didn't recognize on the first one. Images aren't strong. Not recognizing RV dilation or the septal flattening be critical fails. Inadequate, you know, when someone asks you, do you think this patient's in tamponade, not being able to have any reasonable discussion around that, I think would be a critical fail. Again, lack of recognition of the exudative process at play there. Are you seeing that? Is it sharing?
Not really, but we get what you're saying.
Oh, sorry.
No, that's okay.
Sorry, let me
So
just try
are
it
you
again.
still able to pass the case if you miss the diagnosis? Or is it more like, oh, you know, if you have no idea what
Sort
you're
of
looking at
depends.
here, then okay.
It depends on the context. You know, for me, let me just see if I can go through a few more. You know, the fail here would be lack of recognition of, you know, if you don't say the word amyloid by the end of the case, that's a critical fail. You know, that's, you've got to be able to pick up that this is amyloid, right? It's just barn door. But that's, you know, in a point and shoot question, it'd still be there. You know, you've got to be able to recognize it because I've given you everything in this. It's just the most obvious case that we could get, I think. In terms of like a pulse wave Doppler trace, not being able to recognize that there's raised left atrial pressure, that'd be a critical fail.
Mm-hmm.
Constriction case, again, the diagnosis not picking that up would be a critical fail. But it's not subtle, right? We're not giving you super subtle things. You know, everything's in there. It's you know, these are great cases, obviously. You wouldn't fail for missing it on a hepatic vein flow. You know, if you got to this stage and you haven't picked up the diagnosis, you know, you're not getting through it. So those would be the kind of examples. In the point and shoot, maybe saying things like, not recognizing there's a pericardial effusion and not recognizing that there's stuff inside it. That'd be the pass or fail. Saying that there's severe LV dysfunction. So I guess it would be the candidates who fail, it's about lack of recognition of pathology and overcalling pathology. Those are where the critical fails come in.
Thank you.
I do not imagine that many of you guys who I know pretty well now would be giving critical fails, I'll be honest. And if you do, you're not going to do 2 of them. Keep going, guys. You're doing a great job. Just practicing recording yourself is awful and worth doing. Just to hear yourselves talk and the cadence that comes through. Try to avoid using and ums. There's a lot of them. Rishi, and again, I hope it's okay to say it. You got quite a few and ums that come through. Yeah. I think maybe also Rob does. It's worth just trying to record yourself to hear how many times it comes through. Nothing that you're saying is wrong. This is not pass or fail. It's just the idea of faking it till you make it. Is the idea that the less and ums, the more confident you sound. When there are lots of and ums in there, it can trick someone who doesn't know you into thinking that you might not be confident. I'm not going to be able to examine any of you. I think I said I would be able to examine Zoe or Rob. Zoe, you're not sitting this year, are you? No, are you this year? No, you're next year.
No, I'm sitting next year.
Yeah. So I think I've said I'm allowed to do Rob, but I'm certainly not going to be able to examine you two, so that you might not know the examiners as well. So just trying to show that confidence, which is clear, concise, confident communication, no no ums, look them in the eye. You don't have to talk straight away. You can have a think about things, but when it comes out, just say it with confidence.
Thank you, Sam.
Great
Thanks,
job,
Sam.
guys. Please do reach out if you want any more sessions or something, and I'll try and do a few more of these in the next few weeks.
Thank
Great
you.
to see you guys. Take care. Bye.